So welcome again, everyone. Here today, we're talking again to Dr. Tatiana Haverluk about portable ultrasound, point of care ultrasound, and soft tissue POCUS for everyday lump.
Hi, Randy. Nice to be back. This was a case of a younger patient who's an athlete who came in with some axillary swelling pain, and the provider was not certain if there was an abscess there that needed to be drained because there was some induration, there was some tenderness, but they were not really appreciating the fluctuance that would be kind of in your face, like there's definitely pus there. So they decided to perform an ultrasound, and the ultrasound actually showed no fluid collection, so no abscess. And in this case, the patient avoided unnecessary procedure, and they got started on antibiotics, which was indicated.
So what ultrasound signs reliably tell cellulitis from an abscess at the bedside?
Well, if you have an abscess, for example, you will see a fluid collection which appears anechoic or black on ultrasound. Sometimes will have some debris in it as well. You can also try to compress it a little bit. It's uncomfortable for the patient, but if with compression, kind of the debris starts swirling, that's called a swirl sign, and it's also more of an indication that there's an abscess that needs drainage. Versus about the cellulitis, you're not going to see this nicely formed fluid collection. Instead, you're going to see some thickening of the dermis. You can see some fluid in the adipose tissues, but it's kind of layered. It's called cobblestoning, and there's an example of that in the article. And you can also see some changes in the echogenicity of the dermis and the adipose tissue. So it might be more echogenic, or it's called hyper echoic. So those would be some of the changes. So I would say for cellulitis, you're looking for cobblestoning and thickened dermis, an adipose layer. And with abscess, you're looking for fluid collection and maybe a swirl sign.
Yeah, that makes sense. So what are some pearls and pitfalls new users need to know to avoid misdiagnosis, mistaking vessels or lymph nodes or fluid? You talked a little bit about fluid a second ago, how to sort of identify that, but what are some of the other common misdiagnosis?
Yeah. So first of all, just seeing some layered fluid or cobblestoning on ultrasound doesn't automatically mean that the patient has cellulitis. There's fluid in their tissue, right? Their soft tissue. So that can also be just simple edema. So you do need to clinically correlate, right? Usually if it's bilateral swelling and some erythema, it's probably more consistent with edema than cellulitis. So definitely use your clinical judgment there. Yeah, other things to consider would be, especially if you're scanning in the neck area or the groin. So there could be mimics for an abscess, including in older patients, it could be an aneurysm. That would be a really bad thing to try to IND at the bedside, right? So you do want to sometimes, if you're scanning in those areas, put color flow on your ultrasound image to make sure that there's no blood flow in that area. Another thing could be like an inguinal hernia, for example, that is causing a bulge and pain, and it's actually incarcerated hernia and not a an abscess, right? So ultrasound can be really helpful. And then lymph nodes are super common, and lymph nodes do look a little bit hypoechoic, a bit like an abscess on ultrasound. But the difference with a lymph node, usually they have a hyperechoic center, and a lot of times they'll also have color flow. So you do want to put color flow on to make sure that the structure is not lighting up. If it is lighting up, then it's not an abscess.
Describe color flow because I've not heard that term before. Describe what that is.
Oh, it's a function on the ultrasound device. So normally we scan in what's called B mode, or brightness mode, which gives you that grayscale. And if you go into the color mode, it is actually picking up any kind of motion on the screen, and you can make adjustments, whether it's going to pick up how sensitive it is with the motion. But it will give you, if the motion is towards the probe, it will give you a red color. And if it's away from the probe, it will give you a blue color. And if it's really bright on the screen, for example, like yellow or white, it's moving fast. So there are different ways to look at it as well. But basically, if there's, say, an artery there, it will also be pulsatile flow, either blue or red, because that doesn't matter whether it's an artery or vein, it's more the pulsation. Yeah, so that's what you can see with color mode.
Interesting. So any other approaches to I guess everyday lumps? How would your approach be, or what would you just do? A normal physical exam, and then if you notice something from a physical exam, you would do ultrasound. Is that sort of how you would approach?
Yeah, and sometimes even looking at the lump and seeing whether it's a cyst versus more of a solid structure or, a lipoma, ultrasound can actually help you. Like, and you can tell a patient, hey, like it looks like this is a cyst versus maybe this is an infected cyst if it's really red and there's some debris in it, versus this is a vascular structure, versus it looks like a lymph node, versus this is a lipoma that has some echogenicity, and maybe you would give them some surgical follow-up to further evaluate it. So it definitely makes a difference. Another thing I like to do with ultrasound is see, for example, measure how deep this finding is.
Yeah.
Can I even like get to it easily, in the office? And also how big it is, so you can actually measure it in all 3 dimensions, and maybe even record it in a chart. So if the patient comes back and they continue having issues there, you can see whether it's enlarging or not.
Coding reimbursement type issues associated with this. Any caveats or anything to look for there as far as documenting or coding?
I mean, once again, it's really, having the medical necessity explained in the medical decision part of the chart, and then having the procedure note with your views and like what views you obtained, what were your findings, the timestamp, who performed it, what the indication was. And then there's actually 2 ways to bill for it. One would be procedural guidance. So if you ended up actually doing an IND and using the ultrasound kind of live while you're doing it or dynamically, to make sure you are in the right place, you could bill it as a procedural guidance versus if you're just looking at a lump or seeing whether, abscess is there and measuring it, it would be more of a diagnostic CPT code.
Excellent. That's great. Well, thanks again for bringing this case forward and for taking time to discuss this today.
Of course. Thank you so much.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.